Got it?
Yeah, it's working.
Okay.
Yeah.
All right.
All right, so we're all good to go. All right, thank you, Rudy. Okay, so just to let you guys know, we are doing, again, Chapter 1, Chapter 4 today, and also Chapter 7. When we get to Chapter 4 and Chapter 7, there are some slides, just a couple of slides that I will omit, and I'll let you know when we get there. For this particular chapter, Chapter 1, we will do all the slides in its entirety. Okay? So with Chapter 1, this just basically talks about basic terminology that you guys will be working with pathophysiology, so just basic terms, nothing too crazy. But keep in mind that I will give you examples of each term, okay, as we go through. Now, when we are looking at pathophysiology, which is the study of diseases, what's going to happen is that we will break down these diseases in these particular categories that I'm going to give you right now. So the first category here is going to be what is called the etiology. Etiology is what we consider the cause of the disease or the known cause, okay, of the disease. So say, for example, if someone has a bacterial infection, okay, somewhere in their body, obviously if we know that it's a bacterial infection, we know the known cause is that particular bacteria, whether it's a streptococcus or whatever it may be, okay. Now, there are some diseases that don't have a known cause or known etiology. And those diseases are what we consider what are called idiopathic, okay? So for example, sometimes if you ever study scoliosis, sometimes people that do have scoliosis, most of the time it is idiopathic, meaning that they don't know what causes this sort of abnormal curvature, it just happens, okay? The other thing here that's listed is something called androgenic. This can result from unintended and unwanted medical treatment. So what happens here, and this is actually one of the things that fortunately or unfortunately keeps you guys busy, okay, as nurses. So what's going to happen here is that, say for example, you're treating a patient for one thing, and then say a side effect of that particular medication may be acid reflux or whatever else. And so now you have to give a patient now something else for the acid reflux, okay? So this is what happens with this type of condition, okay, or situation. Now, I'm sorry, that's saying the same thing. Now, the other thing that happens here is what we call risk factors. Some diseases don't have a known cause, but they do have tons of risk factors involved in them. One, for example, we know that cancer, we don't have the known cause for it, okay, and know, okay, but this is what causes it, but we know that there are some risk factors that are in play that can possibly lead a person into this situation. Also, pathogenesis is when we're talking about the evolution of the disease. So when the disease process begins from that cellular level that I was telling you about earlier, to going from tissue to the organ system, and so forth. So what I'm going to do now is walk you through, let's say, some risk factors, and then I'll walk you guys through the pathogenesis of a particular disease. So for example, let's take arthrosclerosis, for example. What are some risk factors that you know, common knowledge of risk factors for arthrosclerosis?
What is that?
Oh, I'm sorry.
Oh, that's like heart.
Okay, arthrosclerosis, did you not learn that? Who did you have? You had me for Fizz, I told you arthrosclerosis.
So smoking.
Yes, so what happens with arthrosclerosis, if you don't know what that is or remember, arthrosclerosis is going to be plaquing in the arteries. Okay, and this plaque buildup or lipid plaque buildup comes from what? There are some risk factors for this. Okay, cholesterol, and that which comes from what type of situation or lifestyle that a person may have? Diet, a diet that's high in saturated fats. Okay, so in and out, Krispy Kreme, all that good stuff. Okay, so when individuals have these types of diets, yes, they do now tend to have a higher lipid, okay, elevation. Now, what are some other risk factors that kind of play into the arthrosclerosis? There are some other risk factors other than diet.
High blood pressure.
High blood pressure,
High blood
okay.
sugar.
Let me just stop with high blood pressure. So what happens with high blood pressure, hypertension, what happens here is that sometimes with hypertension, it will actually slow down the blood. So this will now produce more of this plaquing formation, especially if the blood is slowed down. I don't want to say stagnant, but definitely slower movement. What else? What are some other risk factors? Not exercising, so sedentary lifestyle, and what goes along with that, also a person that's obese. Okay, so people that do have more weight. What else? Something else that kind of contributes? I think somebody said it.
Genetic?
Genetic could be, yes, definitely genetics play a part in that. And let me just stop there with genetics. With genetics, though, that type of thing is considered a non-modifiable risk factor. So some diseases have a modifiable risk factor where you can educate your patient and say, okay, well, change your diet, let's change this and work on that. But then you also have some non-modifiable risk factors such as genetics. Certain diseases are according to or are more common in people's age, race. Okay, so things like that are non-modifiable, you can't change. What is another risk factor? One more thing I'm looking for. Something that is a lifestyle that people do.
Smoking?
Smoking, very good. What happens here with smoking definitely makes the blood slower. Okay, it makes the blood move slower during vascular movement. You will notice that we will talk about smoking about probably almost every week in this class, if not every week, every other week. Anyone that smokes in this class, okay, not to scare you, but you will probably think twice. You don't have to raise your hand, but you will probably think twice about smoking by the time that we're done with this course. Because I will show you, and not that I'm trying to show you, but this is how the diseases are set up. I will show you how smoking can not only cause a lot of damage to your respiratory tract, but then also the carcinogens and what happens with cancer-forming cells. So now that we know about risk factors, okay, so say for example you have your patient that, okay, is a little bit of overweight, okay, patient may have a sedentary lifestyle. Say this individual works part-time, okay, so he's home most of the time or half the time of the day, just kind of sitting around watching TV. His diet is poor, consisting of, let's say, Popeyes, okay, In-N-Out, Krispy Kreme, okay, all that good stuff, okay, and he just comes home and eats and just kind of veges out. And so what happens here is this individual now is at risk for forming arteriosclerosis, and especially if you want to add age to that too, and also being a male. They say males are more at risk. Now, what is happening in this person's artery? Okay, this is what I want to walk you through as far as the pathogenesis. So, say for example, we already said all his risk factors. So we know that this person definitely has high cholesterol at this point, okay? And so what's happening here is that lipids are flowing through his bloodstream. So he has an increased amount of lipids flowing through his bloodstream. Now, if you think about the composition of a lipid, and let's just think of the shape, okay, first. The shape of a lipid, do you think it's nice and circular and round, or do you think it has sort of like a jagged edge to it? It has a jagged edge, okay? Lipids are not circular, they're not nicely circular, just like any other type of cells or in our bodies. So what will happen is that because of this jagged edge to this lipid, just imagine these lipids just flowing through the bloodstream, okay? And then all of a sudden, the jagged little edge of that lipid will now cause a little nick to the inside of the vessel, the endothelium. So once now we have a break in the endothelium and it starts to damage the endothelium, what is the next step that you know is going to happen if we have a damage to the endothelial wall? It's going to try to repair itself by doing what? Okay, so the clotting process definitely is going to come into play. And then what else is the body going to do?
White blood cells.
Scarring will come after the clotting, but then also white blood cells. Okay, so keep in mind that the immune system is going to kick in. It will get signaled at this point and say, hey, something's going on over here. Let's send some macrophages to that area to try to take care of the situation, whatever it may be. So when these macrophages come to that area, what happens here is that the macrophages, along with the lipid plaque, because of the composition of it, they get together. Macrophages will try to eat it. But the problem is the macrophage cannot get rid of that lipid plaque, and what will happen is it will now turn it into a big old foam cell. That foam cell will now cause this lipid plaque to be fixated against that endothelial wall, and this is how a lipid plaque forms, okay? Now I'm missing just like 1 or 2 parts of it just to give you a big picture, okay? So this is how that forms against the endothelial wall, and now this person has a fixated plaque, okay? Some of you may know this already. If a person has a fixated plaque, that is considered what? Thrombus or embolus? Thrombus. Okay, thrombus is when it's fixated. Embolus is when it breaks off and flows through the bloodstream. Okay, So a thrombus is fixated, embolus is when it breaks off. This is just to give you an example of the pathogenesis. So what I just explained to you, I just walked you through the pathogenesis of arthrosclerosis and how that plaquing happens in the artery, okay? So not that you need to know all the steps, and don't worry, because we will revisit this again when we get to cardiovascular diseases, okay? So we talked about the person's risk factors, and that is the pathogenesis. So pathogenesis is taking it from that cellular level, what's happening inside the vessel or inside the tissue or whatever body part we're talking about, and really going through what is happening with that disease process. The other thing that you'll notice that's extremely important, as you know, is your immune system. So you'll notice with any disease that we go through, even some cardiovascular diseases, definitely respiratory diseases, some digestive disorders, you will notice that the immune system will secrete white blood cells. And when these white blood cells try to come and attack, and depending on the disease process, sometimes it makes it worse or it makes the disease really come out. But keep in mind, the immune system is doing what it's supposed to do, okay? But I just want you to understand that the immune system plays a large part in disease process. Okay, so that's that. Now, once this patient has, say, this arthrosclerosis, okay, so going back to the example arthrosclerosis, so now that they have this fixated lipid plaque, okay, what is going on with that vessel as far as blood flow? If we have a fixated plaque just sticking right in the middle of the vessel, what's the issue?
There's pressure behind it.
There's going to be pressure behind it, and not only that, we're also going to have not enough blood flow getting through to the body as it should, okay? And say, for example, if for some reason this arthrosclerosis happens in the coronary artery, now we're talking about a patient not being able to get enough blood flow to the heart muscle itself. And then this patient will now start to experience angina, okay? So the sign that they will have would be chest pain. Now, not to say that if a person has chest pain, they are automatically having a heart attack. That is not the case. And I'll go over that with you in another chapter to go with the differences. But I'm just giving you examples for all the terms we're talking about. So, sign and the symptom of patient will definitely feel chest pain, okay? Now, there is a difference between a sign and a symptom, and I do want you to know this. A symptom is when what they call also subjective feeling, or what the patient feels. Okay, so the patient is going to state to you, I have pain in my stomach, I have cramping, I feel nauseous. Okay, whereas if you're talking about a sign is what is considered an objective finding or an observed finding that you as the nurse will observe. So whether you observe that this patient is pale, if you look at them and you see blood somewhere, or if you notice someone is vomiting, or whatever's going on with that patient, this is pretty much your observation, okay, for a sign. The other thing I want to point out here with sign and symptom, subjective and then objective finding. Subjective and objective finding, this is something that you guys will use a lot, especially with SOAP notes. Which is pretty much the standard, and I use it, everybody uses, it's pretty much the standard way of taking progress notes on a patient. And so what happens with the SOAP note, the SOAP all stands for something separate. So the S portion, and I apologize that I don't have a board in here, and I will have one here the next time. The S stands for the subjective finding for the SOAP note. The O stands for the objective finding. The A from the SOAP note stands for assessment. And then the last letter, P, stands for plan. So we have subjective, objective, assessment, and plan. Okay, so SOAP, our SOAP note. So again, subjective finding is going to be what the patient states, they're feeling this or that or whatever's going on with them. Objective is going to be pretty much what you observe with that patient. With assessment, assessment is also the portion here where you will put your diagnosis. So any type of testing or anything that will give pretty much your, I don't want to say differential, but your final diagnosis as to what's going on will go in that assessment portion. Plan is going to be what is your plan. Okay, so whether it's your nursing intervention or whatever type of treatment or medication, whatever is warranted for that person. Okay, so that's that. And then syndrome, they say, is just a set of signs and symptoms. They say that not yet to determine a disease. Okay, so it could be a combination. Now, once a person has a disease, okay, how does this disease run its course, so to speak? Okay, so keep in mind that there are different stages of diseases. So when someone is infected with something or the disease process begins, it just doesn't all of a sudden just comes out. There is a certain pattern to this. So we do have what is called a latent period. This is a time between exposure of tissues to the injurious agent to the first signs and symptoms appear. So this is a very good example. Is, say for example, you are sitting on a plane. Okay, we know that planes get crowded and there's no room to breathe, okay, on there. And you're sitting next to someone on the plane that has a cold. Okay, this person definitely has a cold virus, and you're sitting next to them, and those little things are airborne, and you know what's going on. Okay, so what's happening now is that by you sitting next to that person and being now at the beginning stages of being infected, okay, from that particular virus, to the beginning signs, maybe not having symptoms yet, signs or symptoms yet, but this is now what we call the latent period. So that disease process is now hit you, and it's now taking place inside your body. Now, say for example, we have a prodromal period. This is now the virus is inside of your body, and now all of a sudden you start to have a little tickle in your throat, okay, and now you start to have a little postnasal drip and all that good stuff, okay, that goes along with the beginning signs of a cold. This is the prodromal period where you now have the beginning signs of that particular disease. Okay, so the disease has now starting, we can say, running its course, so to speak. The latent period, they do say this is where signs and symptoms are mild or silent even. Okay, so the disease process is going on in your body, but you don't have presence of signs or symptoms as of yet. Okay. Subclinical stage, all this means is that, say for example, a patient has a disease and they are still able to function normally. Okay, so people have rheumatoid arthritis, people have diabetes, okay, some people do have gallstones, GERD, whatever it may be, but they're still able to just move about and do what they need to do as far as performing normal function day to day in their life. But that does not mean that they don't have that disease process going on. Now, acute and chronic. Acute and chronic is extremely important because if you're able to determine an acute and chronic situation as far as conditions are concerned, this will kind of give you a heads up on how it should be treated, okay? So what I mean by that, when there is an acute disease that occurs in a person, it usually happens very rapidly, okay? So usually acute conditions happen very rapidly. The disease process progresses very fast. They say sometimes it's short-lived depending on what the disease process is, okay? So next week we will get into a whole chapter on leukemias, and I will show you how acute leukemias are different than chronic leukemias. Acute leukemias have a very aggressive, okay, very aggressive, obviously with signs and symptoms with the patient and so forth, and so I will show you the difference with that. Chronic diseases or conditions take a longer time to run its course, so it takes a little more time to develop. Patients may not have signs or symptoms, unfortunately, until the very end, and by that time it's, you know, kind of too late, okay, depending on what we're talking about. Also keep in mind that sometimes patients can have an acute condition that can turn into something chronic. So if that acute condition does not get relieved or let's say cured, so to speak, this person can continue having this condition pretty much for the rest of their life, and it'll just kind of go, most of the times it'll go sort of like in remission and a re-exacerbation type of thing, but it's still considered what we call chronic. Now, here we go. Exacerbation and remission. Exacerbation is going to be an increase in signs and symptoms, okay? So say for example, I'll give you a good example, I'll tell on myself. I fell in the parking lot in Stater Brothers. Okay, I know. Don't laugh. It wasn't funny at the moment, but now it's funny. Yeah. So it just finished raining, and I don't know what happened. I think I had on some of these clogs like this, and I stepped on the parking divider, slipped, fell. It was embarrassing. I fell in the bushes and everything. So come to find out what happened, I actually sprained my knee pretty badly. And so initially, as soon as I got up, I said, oh, my knee's a little sore, okay. But then, once I got towards the end of my day, after I left and went back to work, towards the end of my day, I really had an exacerbation of signs and symptoms. I mean, my knee was swollen, I was putting ice on it, it was very painful, it was red. So I started to have all the signs of inflammation at that point, okay, so to speak, but it happened kind of hours after. So sometimes this exacerbation may not happen right at that moment, but it could happen later on. And even sometimes with patients that do go through a chronic course of a condition, they could have these exacerbations. So they'll be okay, and then all of a sudden it just kind of flares up, okay? So pretty much similar to sometimes when patients have conditions like GERD and things like that. Now, remission. Remission is when there is a decrease in severity of signs and symptoms, okay? So this is where the signs and symptoms are sort of hidden, or I don't want to say mild, but they're silent. And so what happens here is that your book says that if a person has a remission that is said to be more than 5 years, and I believe this is the protocol for cancer, if I'm not mistaken, that this person is said to be cured. Okay, so if they go into remission for more than 5 years, this person is said to be cured. Excuse me. Okay, so covalence is going to be the stage of recovery after disease. Okay, not much to say about that. Sequela is just a subsequent pathological infection resulting from an acute illness. Say, for example, and this happened to one of my patients, her daughter, I don't know what happened, she cut her foot, stepped on something. And so, they treated her for the cut, went to the ER. And then what wound up happening was days after, the cut became really bad, and then they realized that she had osteomyelitis. Okay, so she really got a nasty bone infection just from the little scrape that happened to her foot. So sometimes these things can happen, okay, just from an acute situation. Okay, now this chart here, you don't have to worry about this. This is nothing to really say about it. Now the next couple of slides, I'm just going to run through really quickly. This goes more into like epidemiology. I don't know, did you guys take epi yet? Yeah. Some people yes, some people no. Okay, if you didn't take it, you'll probably take it next term. But with epidemiology, it's just all the study of diseases and as far as statistics and all that good stuff. Okay, so statistical normality is the estimate of diseases in normal population. So basically what happens here is that they usually do tests to see, okay, well, what type of diseases occur in certain regions and things of that nature, especially looking to see what diseases are more prevalent, okay, in different areas of the country and things of that nature. Reliability is to test the ability to give the same results in repeated measurements. So in order to say that, okay, well, in Rancho Cucamonga, these people definitely have 80% of vitamin D deficiency. Okay, in order to say that, these tests have to be tested over a series of time with the same results. Much like if you remember from biology when you guys did scientific method, and in order to get to a theory, you have to have the same results each time. So this is the same premise here. Okay, so they have to make sure that the measurements are repeated and given the same results. Validity, making sure that the degree of the measurement reflects a true value which is intended to from its measurement. So making sure that it is a valid measurement from whatever clinical trial or whatever is taking place. Predictive value is the extent of the test that can differentiate between presence or absence of the condition. So you want to make sure that even with some things like this, making sure that there is a control group, obviously, to make sure you're getting the right measurement, getting the right data. Okay, and some of this stuff you guys know already. Sensitivity and specificity, I'm sure you guys went over this in micro, if you've had micro, and you know what that is. Probability positive, specificity if it's, probability for negative. So that's that. Now, a couple of things we have to talk about, which are called individual factors with a patient, and let's just say not only patients, but with diseases in general. Keep in mind that when you guys, the first thing that you're going to do with a patient is talk to them. Okay, so you're not even going to start doing anything and pulling out any type of blood pressure cuff or anything, but you will talk to them, see what's going on with the patient. Most of the times before you even touch the patient, you will have a differential diagnosis in your head, okay, just kind of based on their history, what's going on with them, their present signs and symptoms and all that good stuff. So one thing we want to go over is some factors that will kind of help you with formulating that differential. So what happens here is that cultural considerations. That is definitely one thing you definitely want to keep in mind, is that there are obviously, some diseases that are prominent in certain cultures. So say for example, sickle cell anemia, we know, is one disease that is definitely common amongst African Americans and also people of Mediterranean descent. Also, Tay-Sachs disease. Tay-Sachs disease is common amongst individuals of Jewish descent. So some of these diseases that that are more prevalent in certain cultures, and once you see a patient that may have some signs and symptoms that may lead towards that, that will be one of the things that will stay in the back of your head. Age and biological factors. One good example I can give you of this with age, there are some things that do develop as we get older. Okay, so we know, like say for example, with a child, the thymus gland is larger, okay, whereas as you get older, it just kind of shrivels up to a little piece of fat, okay, because we don't really need it as much, especially by the time your immune system is quite developed. The other thing that I can think of with age, another good example is as we get older, I don't know if you guys ever heard of this, but you've ever heard of people shrinking as they get older, and that is true. Okay, unfortunately it is true, because what happens is that your vertebral disc in between your vertebrae that has water, they do lose water, and so you do lose disc height. So as you get older, there's a possibility to kind of go like this. Yes, okay. So it's a possibility, not to say everybody's going to shrink, but it's a possibility. Okay, so certain things like that, you do have to take into consideration, because sometimes patients will come to you or be presented with certain things, and then you'll realize, okay, well maybe that's just a normal aging process, or maybe there is a certain condition going on. Maybe the person does have a compression fracture that, now calls them to have less height, or maybe it's just age. Okay, so things like that you want to pay attention to. Now, gender differences. What do you remember is different between males and females, other than obviously reproductive? we know what's different. Okay, but other than reproductive, what else did you notice from physiology that's different between men and women? Somebody said. Okay, yes, we are fatter, yes. Women tend to have more areas of fat. Men tend to have more areas of muscle mass. Okay, yes. Something else that kind of goes along with that. Well, hormones are going to be different anyway. With males do have a certain amount of estrogen, but not is what females do. So the hormones are going to be off in any way. What I'm looking for is, if you remember, volume, blood volume.
Oh, yeah.
Blood volume is different in males as opposed to females. Also, just fluid volume in general, if you were to look at a male and just kind of take the total fluid volume of a male, it's actually more than a female. These things are important because, just say for example, if your patient has a stab wound, okay, and goes into a hypovolemic shock and you need to give them fluids or what have you, maybe the protocol would be different for a man than a woman, okay, because men definitely require more. Okay, now, situational differences. Situational differences in how your body will adapt to different environments and situations. Again, I like telling stories about myself. I hope you don't mind. But I remember I went to Mammoth, okay, on a ski trip. My first time going into that type of elevation, okay, and I had elevation sickness very badly, okay. And if you know what happens to your blood, so you guys know what happens to your blood when you go on a higher elevation, what happens? You should know this. What happens when you go into a higher elevation?
Thins out.
It thins out, and not only does it thin out, if it's thin, it's actually going to be moving slower, okay? So what your body tries to do, okay, it tries to produce more red blood cells and so forth to counteract that whole situation. But what happens is that people do get tachycardia, okay, so the heart definitely increase, respiratory rate slows down, okay, because of this whole situation. So those are just some signs and symptoms. You may feel nauseous and things of that nature. So elevation sickness is something that can happen when your body's trying to adapt. Now obviously people that live in Mammoth, they're good, okay, they're good to go because the body has now adapted to that environment and that situation. but it didn't feel good. I tell you, my heart felt like it was going to jump out of my throat. Don't know how people, but obviously if you stayed there, I guess, weeks and months at a time, your body adapts to it. Now, the other thing here is time variation. Time variation is also extremely important. So say, for example, you tell a patient to monitor their blood pressure at home, okay? So we know that when you first wake up in the morning, what is your blood pressure? Low, okay? So keep in mind that blood pressure when you first wake up in the morning is at its lowest, okay? Because you're at pretty much resting, or as rested as you could be. And then as you move about your day, blood pressure tends to raise, okay? So very important to know time variations with your body and what's going on, because this will definitely help, especially if you're telling a patient to monitor their blood pressure at home. You want them to make sure they take it at the same time each day. Still with epi. Okay, with epidemiology, patterns of diseases for populations, okay. Now, endemic, epidemic, and pandemic, I'll just go through this really quickly. With the endemic, this is native to the local region. Okay, so with endemic, I always used to give this example, but I guess it's not really an endemic anymore, but vitamin D deficiency. Okay, so we all know that vitamin D deficiency is this big thing, and everybody's vitamin D deficient. And honestly, I thought it was only for, us folks that were on the East Coast in the cold, okay, and not getting enough sunlight. But then realizing that coming to Southern California, that people here are also vitamin D deficient, okay, and I'm thinking, really? But what happens is that, as you know, people work a lot, okay, and we're indoors a lot, school, I mean, you're here in class 5 hours at a time, 10 hours a day if you have classes back to back. So we don't get the adequate amount of sunlight that we need, okay, so I don't know if that's such a good example of an endemic situation, but it is kind of local, okay, situation. Now, epidemic is something that spreads to many people at the same time. A very good example of this would be a foodborne illness. So say, for example, we all go out to Red Lobster, okay, and we all get sick, okay, from something. So, just something like that, everybody at the same time would get very ill, so that falls in the category as an epidemic. Pandemic disease spread to large geographic regions, so pretty much across the board of the globe, I should say. So what do you know is the most common pandemic disease that's out? More common than AIDS.
Cold.
Cold, flu virus. Okay, cold, flu virus. Okay, that is the most common. Okay, more numbers, okay, than the AIDS virus. So, that's that. Now, this is just going over some things I talked about already. So age, ethnic group, gave examples of that, gender, we talked about. Socioeconomic factors and lifestyle. That is another thing that's extremely important. So looking at, definitely if a patient is drinking maybe 10 glasses of wine a week, or smoking, okay, 2 or 3 packs of cigarettes a day, okay. So things like that, you definitely want to look at people's lifestyle, especially if a patient is doing street drugs, okay. Sometimes patients will tell you, hey, I do whatever, okay, and then you have to take that into consideration, okay, well, what is going on? Why is this patient having sort of issues with maybe psychological issues and things of that nature, and you have to kind of tie that together. Geographic location.